that brings to mind these new agents. Do we know about their safety over months, decades? Do we know about them?
Well, we were chatting earlier about the need for patient registry, patient-reported outcomes, the need to monitor the natural history of this disease over time. You know, as Dr. Silverberg is talking about, we are treating the symptoms today, but we're going to come into drugs where we're actually treating the disease. We're actually working within the immune system. So understanding over time what that's doing for the disease and for the patient.
I mean, that's where I was going with this. It's one thing to say we're going to treat all the symptoms. We're going to get rid of the itch. When it comes up, when it flares, we'll give you something else which is symptomatically effective. But these new drugs are getting at the core issue.
Absolutely.
Right? And they're getting at the cause of the disease. And if we can fix that, why not just use them long term? And forget about flares, forget about all of this. In my uneducated way, say just give them the drug that fixes the disease.
Well, I think we're going to need to understand the safety over the long term. And of course, and that's the issue, is that, you know, the patients will have had, we will have patient safety data for a number of patients over a couple of years. But we're talking about many, many years of treatment. And this is always an issue when a new drug, especially a new class of drugs or a new drug in a particular therapeutic area is introduced, is that we're looking at the potential of using the drug a lot longer and for more people in some way than have been studied already. And so there's this big unknown. And that's where black boxes appear later sometimes and sometimes not. And we may find out, for example, that it's a great deal safer to use the new drugs than it is to do some of the off-label things that are already happening, because those are scary drugs in many ways, and they're not studied for long-term use in this kind of a disorder. So we're going to need to see that data. That's why registries are important, or other means of following up, even just a long-term study where the patients who were in phase 2 or early phase 3 and just keep on going, try to keep track of those patients so that we can get a better handle on the safety issues around the drug. Because when we modify the immune system, there are probably other things. There may be other consequences. And we have found that some of the biologics that we use now are much safer than we had thought when they originally came out. The psoriasis drugs come to mind. But there's still patients who have had difficulty with it. So this is one of those ones where the evidence has to be developed. We're going to have to start without it, be cautious, and keep our eyes open and develop that evidence over time.
I mean, all I can tell you is that I now have been in medicine a long time. Yes, residents, it's been a long time. And what has been striking to me, and this is another example of getting to the core of a disease. We started out treating a lot of diseases by symptoms. And I don't mean to beat you up about it. We would say, well, if you can't sleep and you've got an itch, we'll give you a sleeping pill because we had nothing better. But now we're getting to etiology. This is really exciting stuff. And wouldn't it be great if you could put somebody on one of these drugs or something like them and say, you're done? Wouldn't that be terrific?
Absolutely would. And that's kind of what we're seeing now, you know, just as an example with many psoriasis patients, where we can say, look, you know, for the first time ever, you're clear. I don't have to see you 12 times a year. I don't have to see you, you know, deal with the complications and the infections anymore. Here's a prescription. You can have your life back, and I'll see you back, you know, 6 months from now or a year from now. We would love it, as opposed to the, you know, every 3-week follow-up or every 2-month follow-up that we have right now with the monitoring of labs and blood work and everything else. So yeah, I mean, that's exactly what we would love in the field.
Do we have the prospect here? Is that what we're looking at?
That speaks to the return on investment that Jeff's talking about. You know, it's almost like the calculator of what we need. It's not only the medical claims or the pharmacy claims history, it's the medical claims history to really look at the full cost of this patient.
I mean, I don't envy underwriters, and I don't envy insurance companies looking at these drugs which have global effects. And how do you parse it out? And how do you make that jibe with what we used to pay for? This is a real challenge for you guys, isn't it?
Absolutely. If you look at the specialty trends, you know, it's estimated in the next 3 years, what we've paid for drugs is going to double. So ultimately, it's the employer or the patients who have to pay for that, and that's not a sustainable curve.
All right, I was just going to, I thought I heard you say double. I know it was my ears. I couldn't possibly have heard that.
Yeah.
Double.
Between, if you look at any of the databases, between 2012 and 2018, it's a doubling in per member per year spend on drugs, and it's driven by these drugs. So 3 to 4% of the population is driving half our budget.
Arena.
And they're all nodding. They're agreeing
That's
with you.
reflected in premiums and everything else. So it affects everybody.
Okay. Double.
Double.
How do you justify that?
I
mean, how do you justify
Right.
the price? I mean, how do you justify paying that kind of money?
Right. I mean, this becomes difficult because we try not to look at this as a competition between this and a drug that's going to stop a heart attack or cure or stop multiple sclerosis, or limit its advance, or many other things, right? And so we attempt not to make those sorts of comparisons between people and instead say that we're trying to help everybody. We have a lot of people who are members. They have a number of different disorders, including people who have nothing particularly wrong with them, and they have health insurance in order to try to prevent financial calamity if something should happen. And they're paying a premium and not getting a whole lot back. And so we have to be cautious about how we spend money. But on the other hand, you don't really want to get in the business of making value decisions between one kind of patient and another.
Sure.
We just don't do that here in America. So right now, what we're trying to do is to make sure that if there's a drug that's effective for a particular disorder, it goes to the right patients, the ones who really need it. And that's a partnership with the physicians and the patients to find out who are those patients and how can we help them, but at the same time we have to make sure that we're not overspending. And part of that is get the right patients started, and if they're not responding, get them off it so you can use that funding for something else.
Sitting across from a patient, and you say to this patient, what's bothering you? The patient may say, well, gee, I'm having angina. Well, that's bad. But another patient may say, I have all this itching, I can't sleep, my life is a mess. That's bad.
That's bad too.
And it's difficult to establish a hierarchy. I mean, I don't think you can go ahead and say, well, gee, preventing heart attacks is life and death, but this isn't.
No, we don't establish that hierarchy, and what we're trying to do is to make sure that everybody is treated fairly. But that becomes difficult because we've got these expensive medicines, and other things in healthcare are expensive too.